Pleasant day. I am Rogeline Valencia, and here with me are Estela Maris Taboga, Joshua Clarion Randalbio, Crystal Ann Cabalbag, and Vincent De Leon. Through this report, we aspire to shed light on congenital and acquired immunodeficiencies from multiple perspectives, offering valuable insights that foster a deeper understanding of the subject matter. Understanding both congenital and acquired immunodeficiencies is crucial for improving patient care, effective treatments, and preventing infections. Defects in the immune system increase susceptibility. Problems in the development and functioning of the immune system lead to a higher risk of acquiring new infections or reactivating latent ones, such as cytomegalovirus, Epstein-Barr virus, and tuberculosis. Cytomegalovirus or CMV, Epstein-Barr virus or EMV, EBV, and TB or tuberculosis exacerbate immunodeficiencies by weakening the immune system. CMV causes severe complications like retinitis in HIV or AIDS and life-threatening conditions in transplant patients. EBV increases risks of oral leukoplakia and lymphomas in HIV, AIDS, and post-transplant lymphoproliferative disorder in transplant patients. TB accelerates disease progression in HIV/AIDS and raises the risk of active TB in other immunodeficiencies. Management includes antiviral or antimicrobial therapy, immune-modulating treatments, and vigilant monitoring with antiretroviral therapy or ART, essential for HIV patients. Immunodeficiency diseases can be congenital or acquired. These disorders resulting from defective immunity are categorized as congenital or primary immunodeficiencies due to genetic abnormalities or acquired secondary immunodeficiencies caused by infections, nutritional deficiencies, or medical treatments. So in simpler terms, congenital or primary immunodeficiencies are internal because it has a problem in genetics, while acquired secondary immunodeficiencies are external and are affected by environment. Congenital immunodeficiencies are genetic defects that impair the maturation or function of the immune system. Approximately 1 in 500 individuals in the United States and Europe are affected by these conditions, which vary in severity. They commonly increase susceptibility to infections. The clinical and pathological manifestations of congenital immunodeficiencies diseases can differ significantly. Some cause severe infections early in life, potentially fatal without treatment, while others lead to mild infections and may only be detected in adulthood. It implies that congenital immunodeficiencies, being genetic disorders, significantly impact the immune system ability to function properly from birth. Overall, people with congenital immunodeficiencies are more prone to infections due to their compromised immune systems. And there are different features of immunodeficiency diseases. There are B-cell deficiencies, T-cell deficiencies, and innate immune deficiencies. So they are different from histopathology and laboratory abnormalities, and they also display common infectious consequences. When it comes to B-cell deficiencies, they are often absent or reduced follicles and germinal centers in lymphoid organs. They are also characterized by reduced serum of Ig levels. And its common infectious consequence is the pyogenic bacterial infections, enteric bacterial and viral infections. On the other hand, T-cell deficiencies may be reduced T-cell zones in lymphoid organs, also reduced DTH reactions to common antigens, and defective T-cell proliferative responses to mitogens in vitro. And viral and other intracellular cellular microbial infections like pneumocystis jirovecii, other fungi, and some cancers like EBV-associated lymphomas and skin cancers. Defective T-cell proliferative responses to mitogens in vitro as well. And then innate immune deficiencies. So variable depending on which component of innate immunity is defective. And it is also in result consequence to pyogenic bacterial and viral infections. Congenital primary immunodeficiencies causes or defects in innate immunity, where abnormalities in two components of innate immunity, phagocytes, and the complement system are important causes of immunodeficiency. Second, the defects in lymphocyte maturation. Many congenital immunodeficiencies are the result of genetic abnormalities that cause blocks in the maturation of B lymphocytes. T lymphocytes or both. Third, the defects in the lymphocyte activation and function, where numerous immunodeficiency diseases are caused by mutations affecting molecules involved in lymphocyte activation. Last is the lymphocyte abnormalities associated with other diseases. Some systemic diseases that involve multiple organ systems and whose major manifestations are not immunologic may have a component of immunodeficiency. So when it comes to the defects of innate immunity, this is due to impairing the body's first line of defense against infections. This includes problems with physical barriers like skin and mucous membranes, and issues with immune cells such as phagocytes and natural killer cells. These defects make it harder for the body to quickly affect and effectively respond to pathogens, leading to increased susceptibility to infections. When it comes to the lymphocyte maturation, this is caused by the primary immunodeficiencies by preventing the proper development of B cells, T cells, or both. This leads to a reduced or absent immune response, making individuals more susceptible to infections. These defects can result from genetic mutations that disrupt the processes essential for lymphocyte development and function. Thirdly, the lymphocyte activation and function. This is primarily due to immunodeficiencies by impairing the ability of lymphocytes, which are the T cells and B cells, to respond effectively to infections. This leads to a weakened immune system that cannot properly recognize, attack, or remember pathogens, resulting in increased susceptibility to infections and difficulty clearing them from the body. Lastly, the lymphocyte abnormalities associated with other diseases. These are due to primary immunodeficiencies by impairing the production, development, or function of lymphocytes, which are crucial for a healthy immune response. This impairment can lead to increased susceptibility to infections and other immune-related issues, as the body's ability to defend itself is compromised from birth. Next are the innate immunity-associated diseases. First one is the chronic granulomatous disease, or often called CGD. So this is caused by mutations in genes for phagocyte NADPH oxidase, preventing neutrophils and macrophages from killing microbes. This leads to frequent infections from catalase-producing bacteria like Aspergillus and Candida. The immune system compensates by recruiting more macrophages and activating T cells, forming granuloma-like structures around infections. The most common form of CGD is X-linked due to mutations in NADPH oxidase gene on the X chromosome. So CGD can be life-threatening if not managed properly. It varies in severity, but recurrent infections can lead to serious complications or death. Proper diagnosis involves blood and genetic tests, and treatment includes antibiotics, antifungals, and immunomodulatory therapy. Prophylactic antibiotics and interferon gamma therapy may be used in severe cases. Bone marrow or stem cell transplantation may be considered. Vigilance in monitoring and treating infections is essential to prevent fatal infections.
Leukocyte adhesion deficiency is a rare genetic disorder characterized by defects in the immune system's ability to fight infection due to impaired adhesion of white blood cells, specifically the leukocytes, to blood vessel walls and migration to sites of infection or inflammation. It is caused by mutations in genes encoding integrins, enzymes for selecting ligands, or signaling molecules activated by chemokine receptors disrupt leukocyte adhesion. These mutations prevent blood leukocytes from finding firmly to vascular endothelium and being properly recruited to infection sites. There are three types of leukocyte adhesion deficiency: LAD type 1, type 2, and type 3. The type 1 is the most common type and is caused by mutations in the ITGB2 gene, which encodes a protein called CD18 that is part of a complex involved in leukocyte adhesion. Without functional CD18, white blood cells cannot adhere to the blood vessel walls and migrate to sites of infection, leading to recurrent and severe bacterial infections. The type 2 is caused by mutations in the SLC35C1 gene, which affects the synthesis of sialyl Lewis X, a molecule involved in leukocyte adhesion. Without proper expression of sialyl Lewis X, white blood cells cannot effectively adhere to blood vessel walls, leading to immune deficiency and recurrent infections. Lastly, the type 3 is an extremely rare form of LAD with mutations in the FERMT3 gene, which affects the function of a protein called kinelin 3, and kinelin 3 plays a role in activating integrins, which are proteins involved in leukocyte adhesion. Mutations in FERMT3 impair integrin activation, leading to defective leukocyte adhesion and immune deficiency. So for the common symptoms of LAD, it includes recurrent bacterial infections, delayed wound healing, and purpose formation at sites of infection. The affected individuals may also experience chronic gum inflammation or periodontitis and may have abnormalities in the development of teeth. For the treatment of LAD, it typically involves aggressive antibiotic therapy to manage infections, along with measures to support the immune system. Stem cell transplantation may be considered in severe cases to replace the defective immune system with healthy donor cells. However, outcomes can vary depending on the severity of the condition and the availability of suitable donors. Early diagnosis and treatment are crucial for improving outcomes and reducing the risk of complications in individuals with leukocyte adhesion deficiency. Genetic counseling may be recommended for affected individuals and their families to understand the inheritance pattern of the condition and to discuss the risk of passing it on to the future generations. Next is the Chidiac-Higashi syndrome, an immunodeficiency disease in which the lysosomal granules of leukocytes do not function normally. The immune defect affects phagocytes and natural killer cells and manifests as increased susceptibility to bacterial infection. The Chidiac-Higashi syndrome is an extremely rare autosomal recessive disorder characterized by abnormalities in the lysosomal trafficking regulator gene, leading to impaired function of lysosomes within cells. Lysosomes are cellular organelles responsible for digesting and recycling various molecules, and their dysfunction in CHS results in a variety of health problems. The treatment for Chidiac-Higashi syndrome focuses on managing symptoms and complications. This may include prophylactic antibiotics to prevent infections, prompt treatment of infections with appropriate antibiotics, regular monitoring and management of bleeding tendencies, and supportive care for neurological symptoms if present. Stem cell transplantation may be considered as a potential cure for Chidiac-Higashi syndrome, particularly in severe cases. However, this procedure carries risks and is not always successful. Due to the rarity and complexity of Chidiac-Higashi syndrome, a multidisciplinary approach involving various healthcare professionals, immunologists, hematologists, dermatologists, and genetic counselors are often necessary for optimal management and care of affected individuals. Next, on to the defects in lymphocyte maturation. Severe combined immunodeficiency is a rare genetic disorder characterized by a profound deficiency in the immune system, leaving affected individuals extremely vulnerable to infections. It is often referred to as bubble boy disease because of the famous case of David Vetter, who lived most of his life inside a sterile plastic bubble to protect him from germs due to SCID. SCID typically manifests early in life, often within the first few months after birth. Babies with SCID are highly susceptible to recurrent and persistent infections caused by bacteria, viruses, and fungi, and other pathogens. These infections can be life-threatening if not promptly treated. The underlying cause of SCID is genetic mutations that affect the development or function of immune cells, particularly T cells and B cells, which are crucial for fighting infections. Without functional T and B cells, the immune system cannot mount an effective response against pathogens. The following are the types of severe combined immunodeficiency. X-linked SCID is caused by mutations in the IL-2RG gene located on the X chromosome. This gene provides instructions for making a protein critical for the development and function of immune cells. S-linked SCID primarily affects males because they have only one X chromosome. Females have two X chromosomes, so if one X chromosome carries a mutated IL-2RG gene, the other X chromosome may compensate for the defect. Functional deficiencies of X-linked SCID is that markedly decreased T cells, normal or increased B cells, and reduced serum immunoglobulin. And next is the autosomal recessive SCID due to ADA or PNP deficiency. ADA or adenosine deaminase deficiency and purine nucleoside phosphorylase deficiency are two types of autosomal recessive SCID. These deficiencies impair the function of enzymes involved in purine metabolism, leading to toxic buildup of metabolites that are particularly harmful to developing lymphocytes. Without functional lymphocytes, the immune system cannot effectively fight infections. Progressive decrease in T and B cells, mostly T cells, reduced serum immunoglobulin in ADA deficiency, normal B cells, and serum immunoglobulin in PNP deficiency. Next is the autosomal recessive SCID due to other causes. There are various other genetic mutations that can lead to autosomal recessive SCID. These mutations may affect different aspects of immune system development or function, resulting in similar severe immunodeficiency. Lastly, DiGeorge syndrome. DiGeorge syndrome, also known as 22q11.2 deletion syndrome, is a genetic disorder caused by a small piece of chromosome 22 being missing. This deletion results in a wide range of symptoms, including immune system abnormalities due to the underdevelopment of the thymus gland, which plays a crucial role in the maturation of T cells, a type of white blood cell important for immune function. The severity of immune system dysfunction in DiGeorge syndrome can vary widely among affected individuals. So, for the treatment options for SCID include stem cell transplantation, gene therapy, enzyme replacement therapy, and antibiotic and antifungal medications. Early diagnosis and treatment are critical for improving outcomes in individuals with SCID. Without intervention, SCID is often fatal within the first year or two of life due to severe infections. However, with appropriate medical care, many individuals with SCID can lead relatively normal lives. And for the selective B cell deficiency, it refers to a group of primary immunodeficiency disorders where there is a specific impairment in the development or function of B cells, which are responsible for producing antibodies. So the first one is the X-linked amyoglobulinemia, or XLA. It is a primary immunodeficiency disorder caused by mutations in the BTK gene located on the X chromosome. BTK, or Bruton's tyrosine kinase, is crucial for B cell maturation. In XLA, there is a severe deficiency or absence of mature B cells, leading to low levels of immunoglobulins in the blood. This results in increased susceptibility to bacterial infections, particularly in the respiratory tract. XLA primarily affects males because they have only one X chromosome. Next is the immunoglobulin heavy chain deficiencies. The immunoglobulin heavy chain deficiencies are a group of disorders characterized by defects in the production of specific types of immunoglobulin heavy chains. Immunoglobulins, also known as antibodies, are composed of heavy and light chains and play a vital role in the immune response. Deficiencies in heavy chains can lead to reduced levels of certain types of antibodies, impairing the body's ability to fight infections. There are different types of immunoglobulin heavy chain deficiencies, each associated with specific genetic mutations affecting the production or function of heavy chains. So, these disorders result in compromised humoral immunity, leaving affected individuals susceptible to recurrent bacterial infections, particularly in the respiratory and gastrointestinal tracts. Treatment often involves lifelong antibody replacement therapy to provide the missing antibodies and prevent infections. Prophylactic antibiotics may also be prescribed to reduce the risk of infections. Additionally, avoiding exposure to infectious agents and maintaining good hygiene practices are important measures to help manage these conditions.
Next is a selective B cell deficiency. The most common clinical syndrome caused by a block in B cell maturation is X-linked agammaglobulinemia, first described as Bruton agammaglobulinemia. In this disorder, pre-B cells in the bone marrow fail to expand, resulting in a marked decrease or absence of mature B lymphocytes and serum immunoglobulins. The disease is caused by mutations in the gene encoding a kinase called Bruton tyrosine kinase, resulting in defective production or function of the enzyme. So, selective B cell deficiency is a disorder where B cell maturation is blocked due to mutations in the Bruton tyrosine kinase gene. This leads to a decrease or absence of mature B cells and immunoglobulins, making individuals prone to infections. Next is the X-linked hyper IgM syndrome. This results from defective B cell switching due to gene mutations like CD40L or CD40, impairing T cell dependent immune activation. This leads to high IgM levels and reduced immunity against intracellular microbes. Boys with this syndrome are prone to infections like pneumocystis jirovecii. Another type caused by mutations affecting the AID enzyme shows humoral abnormalities without cellular immunity defects. So, X-linked hyper IgM syndrome is a disorder where there's a defect in the gene responsible for producing CD40 and CD40L, leading to impaired immune system function. So, this causes high levels of IgM antibodies but lower levels of other types of antibodies. It results in increased susceptibility to infections, especially by intracellular microbes. Next is IgA deficiency. Genetic deficiencies in specific Ig isotopes like IgA deficiency are relatively common, possibly affecting 1 in 700 people. In most cases, IgA deficiency does not cause clinical issues, but in some individuals, it can lead to sinus, lung, or intestinal infections. The underlying cause of these deficiencies is often unknown, although in rare cases, mutations in Ig heavy chain constant region genes may be responsible. So, IgA deficiency is a condition where the body doesn't produce enough immunoglobulin A, an antibody that helps protect against infections in the mucous membranes of the respiratory and digestive tracts. It's one of the most common primary immunodeficiency disorders, and people with this deficiency may be more prone to infections, particularly in the respiratory and gastrointestinal systems. So next is the common variable immunodeficiency. It is a heterogeneous group of disorders characterized by poor antibody response to infections and reduced levels of IgG, IgA, and sometimes IgM. Causes include defects in genes related to B cell maturation, activation, or T-B cell collaboration. Some patients have mutations in gene for receptors or co-stimulators important in T cell B cell interactions. Symptoms include recurrent infections, autoimmune diseases, and lymphomas. So it's called common variable because the specific immunoglobulin deficiencies can vary among individuals. People with CVID have impaired antibody production, which weakens their immune system's ability to fight off infections. And this can lead to recurrent and severe infections, particularly in the respiratory and gastrointestinal systems. Next is the effective activation of T lymphocytes. We have the bare lymphocyte syndrome. It results from mutations that prevent the expression of class 2 major histocompatibility complex or MHC molecules due to transcription factor defects. Class 2 MHC molecules present peptide antigens to CD4 plus T cells, essential for T cell maturation and activation. The disease is characterized by a severe decrease in CD4 plus T cells due to impaired maturation in the thymus and inadequate activation in peripheral lymphoid organs. So this is caused by mutations that stop the production of certain proteins needed for the immune system to work properly. Specifically, these mutations affect the expression of class 2 major histocompatibility complex molecule which are crucial for presenting antigens to CD4 plus T cells. And without these molecules, CD4 plus T cells can't mature properly in the thymus or get activated in other parts of the body, leading to a severe decrease in their numbers. And this results in a weakened immune system, making the body more vulnerable to infections. Next is the hemophagocytic lymphohistiocytosis or the HLH. It involves systemic immune cell activation, particularly macrophages, often triggered by infections, and it is often caused by genetic disorder impairing cytotoxic CD8 plus T cells and NK cells, such as mutations affecting perforin or proteins involved in granule exocytosis. This leads to persistent viral infections and excessive IFNY production, which activates macrophages excessively. In some cases, highly activated macrophages may induce red blood cells, hence the name of the syndrome. So, HLH is a condition where the immune goes haywire due to genetic issues, leading to excessive activation of immune cells, especially macrophages. This can be triggered by infections and results in persistent viral infections and too much IFNY production. The overactive macrophages may even start to consume healthy red blood cells, causing serious problems. Next is the lymphocyte abnormalities associated with other diseases. We have the Viscott-Aldrich syndrome. This X-linked disease is characterized by eczema, reduced blood platelets, and immunodeficiency. It is caused by a mutation in a gene encoding a protein critical for binding to various adaptor molecules and cytoskeletal components in hematopoietic cells. Due to absence of this protein, platelets and leukocytes develop abnormally, resulting in smaller size and impaired migration. So Wiskott-Aldrich syndrome is caused by mutations in encoding the Wiskott-Aldrich syndrome protein, which is essential for regulating the cytoskeleton of immune cells. As a result of these mutations, individuals with Wiskott-Aldrich syndrome have dysfunctional immune cells, particularly T cells and platelets. This leads to a weakened immune system, making them more susceptible to infections and an increase of bleeding due to low platelet counts. Next is the ataxia telangiectasia. This syndrome is characterized by ataxia or gait abnormalities and telangiectasia vascular malformations and immunodeficiency. Results in a gene involved in DNA repair. These mutations lead to faulty DNA repair processes such as during antigen receptor gene segment recombination, resulting in impaired lymphocyte maturation. So AT is caused by mutations in the ATM gene, which plays a critical role in repairing damaged DNA. As a result, individuals with AT are more sensitive to the effects of radiation and have an increased risk of developing certain cancers, particularly leukemia and lymphoma. In addition to neurological symptoms and telangiectasias, individuals with AT may also experience immune system abnormalities, increased susceptibility to infections, and respiratory problems due to lung damage. So, therapy for congenital immunodeficiencies encompasses a range of approaches tailored to the specific type and severity of the condition, aiming to bolster the immune system's function and mitigate susceptibility of infections. First is the immune system reconstitution, enhance immune function, and protect against infections in those with immunodeficiencies. Second is the IVIG therapy. Patients with selective B-cell defects like X-linked agammaglobulinemia often receive intravenous immunoglobulin injections from healthy donors to provide passive immunity. This therapy is also used for other immunodeficiencies affecting the antibody production. Next is hematopoietic stem cell or transplantation or HSCT. The primary treatment for a carefully matched donor where healthy stem cells are transplanted into the patient to rebuild the immune system. Lastly is the gene therapy. Gene therapy corrects genetic immunodeficiencies by introducing normal genes into patient cells to restore immune function. Although challenging, successful cases like X-linked SCID involve introducing normal genes into bone marrow stem cells for transplantation, achieving immune system restoration. So, acquired secondary immunodeficiencies or acquired immunodeficiencies, also known as secondary immunodeficiencies, occur when the immune system becomes weakened later in life due to factors such as infections, medications, or other medical conditions. So, unlike primary immunodeficiencies, which are usually genetic, acquired immunodeficiencies develop after birth. So, the secondary immunodeficiencies often result from acquired abnormalities rather than genetic mutations. In developed countries, common causes include bone marrow cancers or leukemias and immunosuppressive therapies used in cancer treatment or to prevent graft rejection. Chemotherapy and irradiation can damage bone marrow cells and lymphocytes, leading to immunodeficiency. Similarly, immunosuppressive drugs and newer therapies designed to modulate immune response can also cause immunodeficiency as a complication. Additionally, protein calorie malnutrition prevalent in impoverished or famine-stricken regions can result in deficiencies across the immune system components, contributing to immunodeficiency.
So, in secondary immunodeficiency, it affects the functions of phagocytes and lymphocytes that causes this acquired immunodeficiency syndrome. So, the epidemic acquired immunodeficiency syndrome, or as we know as AIDS, is a great example of a secondary immunodeficiency diseases. So this AIDS or acquired immunodeficiency syndrome is actually caused by an infection known as HIV or human immunodeficiency virus. And this HIV virus is said to be an RNA virus on the lymphocytes, wherein the HIV targets and destroys CD4 plus T lymphocytes, leading to progressive loss of cell-mediated immunity and increased susceptibility to opportunistic infections and cancers. So, in here, the HIV infection, it usually targets the T helper cells, and they are being depressed, leading to suppression of the immune system. And as the immune system is being depressed, of course, the individual is susceptible to infections, and a series of diseases develop until death. Next slide. So, iatrogenic immunodeficiencies is usually due to mutations with genes that are critical for the immune system functions. So they can lead to specific vulnerabilities of infections depending on which part of the immune response is affected. So in this slide, I will show you or give you some of the most common causes of immunodeficiency diseases and how it's processed on the compromising immune response. So first is the HIV infection or the human immunodeficiency virus infection, wherein its mechanism is of course the depletion or the depression of CD4 plus helper T cells. And second is the irradiation and chemotherapy treatments for cancer, wherein it decreased the bone marrow precursors for all leukocytes. Third one is the immunosuppression for graft rejection and inflammatory diseases, wherein it depletes or it shows the depletion or functional impairment of the lymphocytes. Fourth is the involvement of bone marrow by cancers known as metastasis or leukemias, wherein it shows a reduced site of leukocyte development. Next one, we have the protein calorie malnutrition, wherein the metabolic derangements inhibit lymphocytes maturation and function. And the last one is the removal of spleen, as it shows a decreased phagocytosis of microbes. And on the next slide, let's move here again. Okay, so acquired immunodeficiency syndrome or AIDS, just like what I have told you earlier, it is caused by human immunodeficiency virus, and this HIV is said to be a retrovirus. A class of a retrovirus that infects cells of the immune system, mainly CD4 plus T lymphocytes, and causes progressive destruction of these cells. So, an infectious HIV particle consists of two RNA strands within a protein core surrounded by a lipid envelope derived from infected host cells but containing viral proteins. So, the acquired immunodeficiency syndrome or AIDS, it is a structure and genes of the human immunodeficiency virus or HIV, where an HIV-1 virion is shown next to a T cell surface. HIV-1 consists of two identical strands of RNA and associated enzymes, including reverse transcriptase, integrase, and protease, packaged in a cone-shaped core composed of the P24 capsid protein with a surrounding P17 protein matrix, all surrounded by a phospholipid membrane envelope derived from the host cells. So I will show you the life cycle of HIV, where it consists of the following sequential steps. First is the infection of T cells, wherein HIV infects the T helper cells or the T lymphocytes, macrophages, and monocytes. And next is the right, so the virus enters the nucleus of the host cell, and there it uses its own reverse transcriptase and convert its RNA to DNA. Now, next is the production of a DNA copy of viral DNA and its integration into the host genome. So, when the viral DNA is integrated with the host cell or the host DNA replicates, and the HIV DNA also replicates, and it produces multiple copies of HIV DNA. And right in there, the viral DNA are now being expressed, and production of viral particles are being shown there. So the viral DNA, just like what I have said earlier, for us to understand it more deeper, the viral DNA now produces the mRNA, and new viral particles are being synthesized. And after they come out of the lymphocytes, they spread the infection by infecting new cells again.
So let's move on to the pathogenesis of disease caused by HIV, or the human immunodeficiency virus. Let's start here. Oh, sorry. Let's go back there. Let's start here. From the primary infections of the cells in the blood mucus. Briefly introduce HIV as a lentivirus caused by AIDS. Mention its modes of transmission primarily through blood, genital fluids, and from infected mothers to newborns. The infection process described the steps of HIV infection, interaction with the CD4 molecules, and other cellular receptors. Again, other cellular receptors, virus cell fusion and entry, expression of viral genes leading to production or latent infections, and different outcomes in CD4 plus lymphocytes and macrophages. Moving on to the virus variability, the high heterogeneity of HIV strains, and mentions the specific genetic sequence affecting pathogenic pathways and immune response resistance. Now, this host immune response neutralizes the antibiotics and cellular immune responses and suppressing the virus for many years. The importance of CD8 plus cell antiviral activity and in long-term survival. Also, the treatment and prevention for this one will be tackled as we goes by. Next, here are the clinical features of HIV infections and AIDS. The acute HIV syndrome is the early HIV infection. Patients may experience a mild acute illness with fever and malaise correlating with the initial viremia. This illness subsides within a few days, and this enters a period of clinical latency. When I say latency, there is a delay regarding on the symptoms. Some patients experience this kind of latency. Actually, all of the HIV patients
having or experiencing latency. Usually, when the symptoms of HIV occurs, parang it's already a tanning on your life. So, mas mahirap na siyang i-cure, prevent the other symptoms as well. Again, the definition of latency here is during the latency, there are many, maybe few clinical problems, but there usually is a progressive loss of CD4 plus T cells in lymphoid tissues and destruction of architecture of these tissues. Eventually, the blood CD4 plus T cells count begins to decline, and when the count falls between 200 cells per millimeter cube, normal level about 1500 cells per millimeter cube, patients become susceptible to infections and are some diagnosed as having HIV. Clinical AIDS. AIDS ultimately causes increase of susceptibility to infections and some cancers as well. As a consequence of immune deficiency, patients not given antiretroviral drugs often are infected with intracellular microbes such as viruses and the fungal pathogens, pneumocystis, girovecci, and non-tuberculous mycobacteria, all of which normally are combated by the T-cell mediated immunity. Moving forward, again, AIDS ultimately causes increase. Okay. The immune response to the HIV is ineffective to controlling the spread of virus and its pathologic effects. Small fraction of patients control HIV infections without therapy. These individuals are often referred to as elite controllers of long-term non-progressors. The current treatment for AIDS is aimed to control replications of HIV or the antiretroviral and the infectious propagations of diseases. Combinations of drugs and that blocks the activity of the viral reverse transcriptase, protease, and integrase enzymes are now being administered early in the course of infection. This therapeutic approach is called combination antiretroviral therapy or ART. The development of effective vaccines will likely be necessary for control of HIV infections worldwide. A successful vaccine probably needs to induce high titers or titers of broadly neutralizing antibodies and can recognize a wide range of virus isolates and a strong T cell response as well as mucosal immunity. Um, in conclusion, the congenital and acquired immunodeficiency present significant challenges to individuals' immune system, impacting their life or the ability to fight infections and maintain overall health effectivity. Congenital immunodeficiency are genetic, often diagnosed in early life, and require lifelong management strategies. On the other hand, acquired immunodeficiency can develop later in life due to the factors such as infections, medications, or underlying medical conditions, necessitating prompt diagnosis and treatment. While advancements in medical science have improved the management of both types of immunodeficiencies, ongoing research and public health efforts are essential to enhance early detection, treatment options, and overall quality of life for affected individuals. Again, that will be all regarding the acquired and congenital and acquired immunodeficiencies. Thank you very much and have a great day.